Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Mara. It's good to be with you again for another breakout session. We're especially thankful for our sponsors today, For Medica, and we're going to stage over to Mary Hardy for a brief introduction.
Good afternoon, everyone. I hope you're enjoying the first day of the NATO 2021 main conference session. Norm and his team have definitely put together a great lineup of topics and speakers, and I'm sure you're having a great day. It's an honor to be a sponsor of this event and play a small part in helping deliver this to you. My name is Mary Hardy. I'm the VP of Business Development at Formedica. And at Formedica, we help our clients and partners assess their patient identity data quality. And through a patented process of data stewardship, both technology and people, we help our clients reduce their identity duplication to less than 1%. And we're really passionate here at Formedica about data standardization and data quality. So with that said, it is my pleasure to introduce the next session, Data Standardization and Tracking During the COVID-19 Pandemic and Beyond. And as we all know, the COVID pandemic definitely amplified the need for data standardization so that organizations like yours could reach patients and members in need at such a critical time. So without any further ado, I'm proud to introduce the next segment, and I'm sure you will enjoy. Thanks.
So here with us today, we have Angie Werner, who will be today's moderator. Angie, ready for this?
Yeah, thanks, Norm. So first, I'd like to introduce Preetam Cholli, who is with Vanderbilt University Medical Center. Preetam will be presenting on COVID-19 surveillance, state trends, and deviations from the national case definition.
Hello, everyone. My name is Preetam Cholli. I'm a resident at the Vanderbilt University Medical Center in Internal Medicine and Pediatrics, and I'm here to present to you this presentation, COVID-19 Surveillance, State Trends and Deviations from the National Case Definition. Objectives of this presentation: I'd like to review relevant concepts pertaining to COVID-19 surveillance, explore the role of public digital dashboards in relaying surveillance metrics, and also highlight study findings from this project, which looked at COVID-19 surveillance data reporting through dashboards, and also highlight implications of our findings for pandemic response. First, some background. Case definitions are uniform criteria that are used to define a disease. This allows for standardized surveillance reporting across different jurisdictions. Case definitions are central to pandemic response. They balance high sensitivity and high specificity and should be easily applicable at the point of care. National definitions are developed by the Council of State and Territorial Epidemiologists. However, state authorities ultimately have discretion in how they publicly report surveillance data. There were multiple surveillance challenges in COVID-19. On a national level, the question came how to develop an effective case definition for a novel, rapidly spreading pathogen, and what should be the criteria for suspected, probable, and confirmed cases. For states, they were tasked with the challenge of building capacity for reliable testing, contact tracing, and surveillance reporting in order to determine and identify cases promptly. In response to these challenges, CSTE and CDC developed multiple case definitions over the course of the pandemic, ultimately setting on a 2021 case definition. This definition included 3 categories of criteria: clinical criteria, laboratory criteria, and epidemiological linkages. I'm not going to go into the details of these different criteria now, but based on what criteria are met, patients are categorized into 3 different case categories. These included suspect cases, probable cases, and confirmed cases. Again, I'm not going to go into the specifics of each of these categorizations, but these have relevance for how states reported cases. Switching to talk about dashboards very briefly. We are all probably familiar with these. These are dynamic, publicly available tools that aggregate and display up-to-date data. And importantly, many state-based dashboards carry local data that's very relevant for individuals and communities. Given the need for standardized surveillance in a pandemic, we were wondering how dashboard data reporting varies from state to state and what implications these variations in reporting have for the COVID-19 response. These questions led us to set up our study objectives. We sought to analyze publicly available COVID-19 surveillance dashboard data across the 50 states to evaluate consistencies and heterogeneities in reporting as compared to the COVID-19 national case definition and metrics. Our methods were the following. For all 50 states, we identified state health department COVID-19 surveillance dashboards and then reviewed, coded, and qualitatively analyzed the dashboards and their linked content, including hyperlinks and health department websites. Of note, we did not analyze publicly available raw data files, only those that were on the dashboards. We evaluated for specific content, including case definitions, percent positivity formulas and methods, and also data on recoveries and deaths. Our results are the following. We found that states reported cases in a variety of ways. Some reported total cases, some reported confirmed cases, some reported probable cases, some reported all of those. State dashboard reports found that 47 states reported total cases, 38 states reported confirmed, and 34 states reported probable. However, there was wide variability in how these different cases were actually defined. Interestingly, only 18 states stated that their definitions were concordant with the CDC definition. The remaining did not. For example, 2 states said that their confirmed cases were those who tested positive, meaning that they tested with either a positive PCR or an antigen test. If you look in the table above, you'll see that a confirmed case per the CDC CSTE definition only means nucleic acid testing, which is PCR, whereas a probable case is antigen testing. 14 states, interestingly, did not report probable cases at all. And 8 states that did report probable cases base it off of lab criteria only, when there are 2 other categories of probable criteria that are not dependent on lab findings. 6 states did not provide any definitions for their case. Now, we also look at case geography. Specifically, how does residency inform each state's case count? This can get a little confusing, but we found that states counted residents quite differently and visitors quite differently in their case counts. 4 states included not only residents, but also visitors and also residents who were not in the state at the time of being tested positive. 3 states included in-state residents as well as residents who were out of the state when they tested positive. 3 states included in-state residents as well as visitors from out of the state who did test positive while in the state. And then 3 states did not specify more than just beyond saying that they were including in-state residents. Of note, 30 states shared no information about the role that residency played in their case counts. Another public health metric that's important for surveillance is percent positivity. This metric indicates the degree of community transmission, the need for more testing, and therefore has policy implications for resource allocation and also potential restrictions in order to try to reduce transmission. 45 states reported percent positivity, while 5 did not. Of note, the percent positivity formulas that were used did vary in many cases from CDC's equation. The majority used a test over test method, which was concordant with the CDC's formula. However, multiple other states used different types of formulas, including person over test, person over person. Another formula, which is highlighted at the bottom, some reported multiple, and 4 states did not provide what their formula consisted of. However, taking this to the next level, different states use different testing data within their percent positivity equations. For example, the CDC uses molecular test data only in their test over test formula. 23 states did this. However, 15 states combined both molecular and antigen testing in their percent positivity equations. Of note, some states did report multiple formulas. Looking at recovered cases and deaths, we found that only 22 states reported recovered cases, and only 18 states provided a definition for what recovered case constituted. 41 states reported deaths. However, only 26 states reported confirmed COVID-19 deaths, 21 reported probable deaths, 12 states did not differentiate between confirmed or probable deaths, and 7 states did not provide a definition for what a COVID-19 death was. In conclusions, there are numerous findings and implications. First, I'd like to start by talking about the general importance of public health surveillance data reporting. Public data reporting fosters accountability and transparency. It enables comparison between different jurisdictions and states. It allows for better monitoring and improvement in quality of care. And most importantly, empowers the public to understand and trust their government's response, and also supports individuals in making informed and risk-minimizing behavior changes. What we found was that there was broad heterogeneity in surveillance reporting across states, as well as between states and federal agencies. This lasted across definitions, data sources, and also the formulas that were used for public health metrics. Now, in some cases, this has little relevance, or may have little relevance. For example, adherence to national definitions for confirmed versus probable might be more semantic for cases that are trying to orchestrate a state response. However, we did find that reliable cross-state comparisons are difficult based on state-reported data. And the differences in data reporting may have implications for state-level response, policy implementation, and also public trust and awareness. To sum up what these implications could be, if we don't know where we are, how exactly do we know where we're going and how to get where we want to be? There are some study strengths and limitations I'd like to highlight. Some strengths are this was a broad review of dashboard surveillance reporting, and it evaluated readily available information that was accessible to the lay public. Some limitations are that the data evaluated was in March and April of 2021. Dashboards may have been updated since then. It's also possible that some data was missed despite thorough searches of dashboards and data definitions on health department websites. However, the difficulty in finding this data might be more illustrative of changes in confirming the publicly reported data and assessing its quality and what it consists of. I'd like to thank you all for your time and attention, and would like to open the floor for any questions. Thank you.
Great, thank you, Preetam. Just want to invite everybody to put your comments and questions in the chat box, and I'll read those as they come in. Norm, I guess this might be actually more of a question for you, but whether these slides will be made available after the sessions. I'm not sure if he's on, so I'll let him comment on that then. But Stacy, we'll get back to you. The next question, so saying that this is a good study and evaluation of differences across multiple sources, and asking you what would be the recommendations to prevent similar problems in the future.
That's like $1 million question, and I don't know that I have the best answer for that. I think the challenge comes because with something that needs to be as coordinated as pandemic response, there are so many layers of people, all with different levels of authority that they've been given through legally and otherwise. So, for example,
Looks like we're getting Preetam back on the line. Just give him a minute to rejoin. Let's see, is your audio working again?
Hi, everyone. Can you hear me?
Yeah, I can hear you now.
I'm so sorry.
Yep,
the
I can
connection got
hear you.
Interrupted. Okay, perfect. So yeah, sorry about that disruption. So yeah, the challenge is really there are different levels of authority different jurisdictions have and different levels of, you could say, command and authority have. So CDC can and CSTE can put together a case definition, but ultimately how things are reported falls under the jurisdiction of each state's governor because the health departments fall within that discretion and authority. So I think it comes to, and also the challenge comes with certain states might have valid reasons for populations and communities. To what degree there had been communication and coordination happening between different dashboard designers across state health departments, and what kind of communication had been happening with health departments guidance. But I'd imagine that the only way that could actually happen from well-intentioned people, necessity of having a systematized and coordinated reporting.
Great, thank you. I think we'll move to the next presentation, and then we might have a little bit of time at the end for discussion with all of the presenters. So thank you, Preetam. Okay, our next presentation will be from Sterling Petersen and Brantley Scott with the Utah Department of Health. They'll be presenting on lessons from using raw data from the all-payer claims database for tracking healthcare utilization during the pandemic.
Today, I'd like to talk a little bit about the lessons we learned from using raw data from the all-payer claims database for tracking healthcare utilization during the pandemic. I'm going to skip these first few slides and jump right into the background. The Office of Healthcare Statistics at the Utah Department of Health has collected claims and eligibility data for the Utah APCD for about a decade. Claims and eligibility data flow into a SQL database on a monthly basis, and these staging tables largely remain unused for analysis purposes. We do some quality control work using them, and that's about it. They just kind of sit there until we do formal processing and normalization on a quarterly or a biannual basis. During the height of the pandemic, though, or I guess I should say the initial height of the pandemic, we began to use that data, the raw unnormalized data, for reporting purposes. And we released a series of reports on telehealth and childhood and adolescent vaccinations, preventive care, and a few other things using that raw data. I've broken this presentation into 5 parts, 5 little lessons, and there are some little sub-lessons that I hope will be interesting and informative to you. The first one is, when using bleeding edge raw data, understanding data completeness is important. And there are 2 little sub-lessons here I'd like to talk about. Well, the first one is data supplier submission cycles. In Utah, data suppliers have an entire month to submit data for the previous month. So if you decide to analyze the raw data, you find that it's incomplete at any given time. We developed some code that would select pairs that had a complete series, but you just had to be mindful that the mix of pairs could vary from run to run, even within the same day, as that data flowed into the system. Luckily, the biggest pairs in Utah tended to have very timely and complete data, but ultimately we found it was best to delay certain analyses until all of the biggest players had submitted. Some of the smaller ones didn't make a notable difference if they were excluded or included, but it was noticeable at times if the biggest players weren't there. The next data completeness lesson is be mindful of the insurance adjudication and claim processing cycles. The claims adjudication process can vary in speed across payer, across claim type, and time. It can be tricky sometimes to identify if a falling trend is due to adjudication lags or just loader utilization. We tried to work around this a little bit by focusing on weekly trends, which allowed us to use partial months. But in many cases, we just had to wait and get more data to decide if it was if a fall in utilization was a true drop in utilization or just due to a data lag. It's more of an art than a science. We couldn't figure out any real hard and fast rules. It seemed to vary across line of business and across payer. Second lesson is when using bleeding edge raw data, understanding the accuracy of fields at the data supplier level is important. And there are two little sub-lessons here I'd like to talk about. In many cases, you want to calculate denominators for rates and things for different subgroups, for example, Medicaid, commercial CHIP. And sometimes you find that the things that you leaned on in the process data aren't readily available in the raw data. For example, if there's an insurance product type code mismatch between claims and eligibility, and it's hard to link the two in the raw data, then you have a problem if they're one or the other isn't accurate. You really want the files to be independent of each other, independently accurate. And so that's just something to be mindful about as you go through it, through using raw data. And the second sub-lesson is sometimes the data might not be capturing everything correctly, and that's particularly true for emerging codes and trends. As an example, there was a managed Medicaid plan in Utah that had very low levels of telehealth utilization for a period of time. As we investigated it, we found that the telehealth CPT modifier codes weren't being sent for some reason. They were being filtered out or blanked out. So it understated their telehealth utilization in the reporting we were creating. So we reached out to the data supplier and made a correction. That's something we probably wouldn't have noted before telehealth became a major concern. So kind of understanding the data quality for emerging codes and trends as they become important can be very, very valuable. A third major lesson, when using bleeding edge raw data, having a fast and reliable data platform is important. There are two little lessons here. Having immediate access to recent data submissions is essential. And luckily in Utah, our vendor provided remote access to SQL views of the live raw data flowing into the staging database. It was very crucial for us to be able to accomplish what we did. Second sub-lesson is having a common schema for all data is helpful, but not strictly necessary. Currently in Utah, trending in the raw data across extended periods of time involves stacking different tables, and these tables have different variable names, unfortunately. There's a separate table for each major iteration of the DSG, which meant that we could trend from 2018 Q2 to current, which was good enough for most projects, but sometimes we wanted to reach back a little bit further, and it was more difficult to do that because we didn't have a common schema for each of those data sets. Lesson 4, having positive working relationships with data suppliers is helpful. And there's only one little lesson here, and I entitled it, Sometimes You Want to Call in a Favor. In late 2020, we asked the data suppliers if they could submit a little bit early so that we could accommodate a flu vaccine analysis that we wanted to complete. And because of the positive relationships that my colleagues were able to cultivate over an extended period of time, many were willing to do so as they were able. And that was very, very helpful in order to push that analysis out the door in a timely manner. Lesson 5. And this is the last one I'd like to discuss today. Being proactive and innovative is important. We were able to showcase the power of the APCD before being asked, and that actually gained the attention of the legislature. In this case, we produced some telehealth reporting, and the reporting gained the eye of one of the legislative analysts, and we found ourselves presenting before a legislative subcommittee the results of our work and answering questions about it. And this kind of bleeds over into the second point here. There are implications for short and long-term sustainability as you're proactive and innovative. Especially in an era when funding can be cut and projects shuttered, it's important that you're always making sure that you're showcasing your abilities and keeping yourself relevant. And that's all I have. Happy to answer questions.
Great, thank you, Sterling. We have a few questions already in the chat, and again, feel free to keep adding those to the chat, and I'll keep an eye on that. The first question is, what is your claim cycle that sometimes you just have to wait?
Yeah, so it really depended on what we were trying to trend here. Some things we could look at data sooner than others. Hospitalizations, for example, tended to take a long time as those go through an extended adjudication process and coding process. But other things like pharmaceuticals, prescriptions, those tended to turn around very quickly. Those pharmacy files, when they're submitted to the state, tend to be fairly complete even for fairly recent periods. So it really depended on what we were looking at, whether we felt like we could use data from the last few weeks, or if we needed to look at over an extended period, last 3 months, 6 months.
Thanks. The next one is, do you use or exclude denied claims, since some of the denials might be attributable to the carrier finding an inaccurate code?
Yeah, that's a good question. That's really getting into the nitty-gritty of data collection. So currently in Utah, we don't collect denied claim lines. So that's just kind of that's been part of the specification from the beginning. And that's potentially a problem for some analyses. You know, because when we want to use administrative claims data as a log of utilization, and we're excluding denied claims, but the services happened, they just weren't approved or paid for by the insurer or the payer, we're losing that information. So in Utah, we currently don't collect those denied claims, so we don't really have any information about that.
Thanks. Then we have, is your live raw data transactional that flows into the staging database?
I'm not 100% sure I can answer this correctly. I'm not sure what is meant by transactional, but when we say live raw data, I just need to take a step back and maybe describe how this works. So each of the payers operating in Utah, each of the major ones, supply eligibility and claims data to the state on a monthly basis in giant flat files. So they're just rectangular, pipe delimited flat files. And those include data for all claims that were paid in the previous month. So when we say live, it's not really a transactional snapshot of what's happened to date to minute. There's always an inherent lag, even under the best of circumstances. Even if everyone supplied their data on the first of the month for the previous month, there would still be a lag there. So it's not live in that sense, but it's current, at least as far as most APCDs go.
I think that answered the question. We got a thank you and a clarification of transactional versus a
Great.
flat file. I think we have time for another question. So there's a question asking if you use freestanding ASTC/ODC data.
I'm not exactly sure what those acronyms mean. ASTC, ODC.
Maybe we can get a clarification and come back to that one at the
Sure.
end. So I ask this other one then. Have you experimented with data imputation methods retrospectively to see if they could lead to approximately similar results with the updated data or not?
Yeah, that's a great question. And we didn't really dive into that too much. But, you know, in theory, it would be great to be able to project a little bit and then, you know, look back and see how well we had done. We didn't do any of that, but that might be a fruitful ground for some research.
Great, thanks. And I did get a clarification on the ASTC/ODC. So it's ambulatory surgical treatment center/outpatient diagnostic centers.
Okay. We didn't use any data from those exclusively. In as much as it was being paid for by a payer, we used it. Many states have separate data collection efforts surrounding ambulatory surgical centers, emergency departments, and patient stays, and perhaps a few others. We didn't look at that data in Utah explicitly for trending, but it's definitely something you can do. I will note that while that data was being collected, we did note that some ambulatory surgical centers actually were closed for extended periods of time, and that was something we had to tackle as a data quality issue.
Great, thanks again, Sterling. And we may have more time at the end for a few more questions. So next I'll introduce our last speakers for this session. So we'll have Meekie Shin, who is with the CDC Environmental Public Health Tracking Program, and Mary Dinsdale, who's with the Oregon Health Authority and the Public Health Division. They'll be presenting on efforts to the standardization and uniformity of administration data from the CDC Environmental Health Tracking Program.
Hello, this is Meekie Shin from the CDC Environmental Public Health Tracking Program. We are very happy to share our work at NADO meeting. Mary, co-chair of our content work group, will present with me, and the title of our presentation is Effort on the Standardization and Uniformity of Administrative Data from the CDC Environmental Public Health Tracking Program. For those who do not know about the tracking program, CDC Environmental Public Health Tracking Program was established in 2002. For more than a decade, the Environmental Public Health Tracking Program has collected, integrated, and analyzed health and environmental data from the national network. Since 2002, tracking recipients have worked with the CDC to develop and build a tracking network. The map on your right side shows our former and current tracking recipient. Currently, CDC funds health department in 25 states and 1 city to develop and implement a local tracking program and data network. The tracking network has data on the environment, exposure, health effect, and the population characteristic. Recently, we added emerging topics such as climate change and the COVID-19 data. On the health effect, hospital and ED visit data are the major data source to build the measures. Using hospitalization data, we have 5 health outcomes on our portal and 4 health outcomes using emergency department visit data. To maintain and upgrade different scientific and technical issues, the tracking program has many working groups. Content work group provides more mechanism for discussing and defining tracking program's surveillance goal and scientific method to improve data qualities. This year, tracking program built 8 different content work groups to deal with different data needs and emerging issues in the environmental health area. Mary?
Yes, the Utilization content workgroup split into 4 sub-teams, which I will be describing in more detail. Next. The first team is the NCDM Guidance Revision Subteam. So tracking recipients have been utilizing NCDM how-to guides and data dictionaries, and over time have identified gaps or need for clarification in these documents. The first major goal of this team is to incorporate best practice and recommendations established by the EPHT Geospatial subteam, provide guidance on race ethnicity coding, provide guidance on different scenarios about how emergency department data may be structured in their state and how to prepare it accordingly, and ensure NCM data documentation matches the schema used for data validation and transfer. Next. The second team is the COPD Asthma IC10 Transition Subteam. Tracking recipients have been getting questions around the changes and trends to COPD and asthma after the IC10 transition, and this subteam wants to explore that in more depth. The first goal is to carry out analysis of COPD and asthma hospitalizations and ED visits from 2014 to present. They will develop guidance and messaging for users and use findings and determine if a manuscript is applicable, depending on the results. Next. The third team is the COVID-19 impacts on non-COVID-19 hospitalizations and ED visits. So the COVID-19 pandemic has affected care-seeking behavior from March 2020 onward. The major goal of this subteam is to understand and quantify to what extent the differences in patient behavior and how this has impacted hospitalizations and emergency department visits for non-COVID-19 illnesses and injuries. Next. The final team is the Essence data for heat-related illness and asthma subteam. So Essence is near real-time syndromic surveillance that may be useful for tracking partners to evaluate NCDM health outcomes and integrate as a new data source into grantee and national tracking portals or dashboards. The major goal of this subteam is to assess the uses, the strengths and limitations, and evaluate whether syndromic surveillance captured by Essence is relevant to tracking and how it compares to hospital discharge data to prepare the NCDMs. Next.
Thank you, Mary. The hospitalization and the ED visit data are our major data source for the health outcome data for the tracking network. The National Environmental Public Health Tracking Network brings together hospitalization data from state and city and provides supporting information to make the data easier to understand. A total of 35 state participants representing 21 states joined the hospitalization content workgroup. The hospitalization content workgroup activities can provide more standardized and uniform data collection solution related to the administration data. By next July 2022, our sub-teams will have a monthly meeting to explore and investigate hospital discharge data to meet the proposed goals. The CDC hospitalization content workgroup will provide a mechanism for discussing and defining surveillance goals, needs, and methods to ensure health exposure and environmental data can be translated into meaningful metrics for use in public health practice and policy and inform the public. We will be happy to share our progress in the next NADO meeting. Finally, I would like to thank you for our participant in the hospitalization content workgroup. Thank you. If you have any question, please feel free to send me email or Mary, and we will be happy to answer any questions. Thank you.
Great. Thank you, Meekie and Mary. Again, feel free to add some comments, questions into the chat box, and I'll be watching that. I'll go ahead and ask a question about the Essence sub-team that you mentioned. How many states did you have that participated or are participating in that sub-team? And when do you expect to share the validation results of that piloting?
Thank you for question, Angie. The Essence data set is very unique. So Essence data is going to give a near real-time data set, and we are thinking to the validation of the Essence data set to alternative data source for the administration data. So right now we have a 9 state like examining the validation study to comparing the Essence data set compared to the hospital discharge data to see the sensitivity study. So we are planning to share our result in the CSTE conference and the next year NADA conference, hopefully. Thank you.
Great, looking forward to that. Looking at the chat box, I don't see anything. I'll ask one more question. You mentioned the different standardized methods that tracking has for pulling data on hospitalization, discharge, and ED visits. Is there a place that people can find those methods and documents?
Yes, if you visit the tracking website, you can find lots of technical documentation for the data source and the standardized data documentation and protocol and indicator template. So I can send you NCDM document, how CDC tracking program standardized each health outcome measure, how we receive the data from the state. I can share the document using the chat box.
Thanks, Meekie. We had a question come in through the chat asking, what are heat-related illnesses?
Mary, do you want to answer?
I don't have the complete list off the top of my head, but I know it includes heat stroke and heat exhaustion. But yeah, we can send documentation that lists all of the ICD-10 codes we look at and also the definition, because we just only include, I believe, May through September for heat illness.
Right.
So yeah, we can provide that documentation.
Yeah, we have a specific ICD-9CM, ICD-10CM code. So we go through the hospital discharge data, and if any patient having a specific ICD-9CM or 10CM code, and then collecting the event during the certain period of the summertime.
Great, thank you. I think that's it for questions specific to this session. So I think we could bring everybody back together and open it up for questions to all speakers. Answered earlier, feel free to put those in the chat box, and I'll make sure that they get to the speakers. I guess, is Preetam on? I'm not sure if his audio dropped again or not. I'll go ahead then and ask Sterling a question for you. You had mentioned the positive relationships with data suppliers and being able to call in favors sometimes because of those positive relationships. So do you have any advice on cultivating positive working relationships with data suppliers?
Yeah. And actually, I think Brantley Scott, who's also on this, would be able to speak to that a lot better than I can. And I kind of regard him as an expert, and the way he works with the payers and in Utah and other data suppliers has been a real example to me and I feel other states. So Brantley, I'd ask you to kind of answer that question about what's the best way to cultivate positive relationships.
Yeah, sure, I can talk to that. Thank you for the question. I think one of the important things, first, treat people with respect. I think, here in Utah, I mean, we have a state mandate, but we also try and recognize that these people are really our partners working with us, and try not to shove anything down their throat, for lack of a better word. So, make sure that you're cordial and you understand that they've got other, work responsibilities. And if you focus on them as partners as opposed to, just something that they have to do, you can get a lot more collaboration. One of the other things that I think we've tried hard to do is to show people how we're using the data, and that we're good data stewards. I think people want to think that the work that they're doing is meaningful, and so really showing the value of what we've done. And we have quarterly meetings where we sort of showcase some of the uses of the data and how the data is being used. Really helps foster that collaborative spirit that we're here to help everyone have better healthcare. Yes. One last thought is, again, like, these people in general are in healthcare because they want to help people. And so if you focus on that, and how we're using the data to help people, they can see the value in what we do.
Great. Yeah, I think those are all really good points. We had one question come in, Meekie and Mary, that's for you, asking to please repeat the database used for the related illness and asthma.
Yeah, we use the inpatient hospital discharge data and the emergency department data. We don't use Essence, as was mentioned, or we don't use all payers, all claims, just the standard, HCUP data sets.
Thanks. I'll see, Preetam, can you hear me? Are you available? No, I think we're still having technical difficulties. All right. Sterling, I'll ask you one more question. If you could comment on any of the analytical challenges that you faced while using raw data versus the process data that you talked about.
Sure. This might get a little into the weeds for some of our audience here, but when you're using the staging data as it's constructed, at least in Utah with our vendor, currently Milliman, when that data is loaded into databases in its raw form, everything comes through as a string or a varchar in SQL terms. So all of a sudden you're dealing with dates as strings and quantities and just integers in general as strings. And so you kind of have to be careful about how you sum things and how you're aggregating things. And you have to just be mindful of that. Raw data also lacks some of that standardization that I personally kind of took for granted. Like, yeah, some people were sending in dates that weren't fitting the format, but our vendor took care of that. So just kind of dealing with variants that formal processing takes care of is something you have to be mindful of as you're using raw data. Also, all the processed enhancements that you kind of expect in an analytics-ready database aren't there. So person resolution, identity resolution, depending on how your database is constructed, it might not be there, and it wasn't in our case. So we just had to rely on insurance identifiers. Also, these staging databases, in many cases, at least in ours, don't include lookup tables. So sometimes you want a little bit of guidance on CPT codes or different aggregations or just different lookup tables, and those aren't there. So you kind of have to pull in the data that you need. I guess in short, you just have to be mindful that these aren't necessarily analytics ready databases. If you sit an analyst in front of it, they'll be able to work with it. But there's a little bit of a learning curve involved. It's not as intuitive and it's not as easy as kind of these fully normalized analytics ready databases. So I think that was something that we ran into.
Great, thank you. And we just had a comment for you, Sterling, thanking you for the observations about dealing with data and the uncontrollable issues that we come across with that. I think we're going to try me asking a question and having Preetam type it for Norm to read. So I already kind of typed it for him, but just asking how standardization might be incentivized across a wide range of federal, state, and other partners or agencies, including academic and nonprofit. So thank.
I'm waiting for the typing magic to occur, Angie. So here we go.
Let's see.
Yeah. Let's give him a minute to type that out, and we'll come back to that.
Yeah, if anybody else has any questions or comments, feel free to add those to the chat box.
One thing I'd also like to share with using the raw database that I've noticed at least is because they're very large flat files, sometimes your queries can take extremely a long period to run, as opposed to the process data is usually more normalized. And so when you're writing code for the raw data, you always need to be extra careful that your code is correct, because you don't want it to run for 3 or 4 hours or even 8 hours and then find out that it wasn't exactly how you wanted. And that can, one of the things I'm thinking that you can eliminate that a little bit is if you create temporary files that are smaller, and you can create some temporary files in the raw data, but that's just another consideration to think about as you're using potentially large raw files.
I'm not seeing a response being typed from Preetam, so we may just end up not getting the answer to that question from him for this session. Oh wait, here we go. All right, Norm.
I got it. All right, so I think going on what I had specified before, generalized community consensus will have to happen through specific agencies in coordination and collaboration. So with public health data reporting through public agencies, having a legislative standard may be something that's desirable.
Great, thank you. All right, I think I guess I'll do a final call for any. Oh, we have one more question that came through. Has any of your data processing vendors taken on geocoding of patient addresses so that it can be used to pull in SDOH data sets?
Yeah, that's a good question. And I think there might have been a separate NATO pre-conference seminar that spoke to this a little bit. Geocoding, it's something that I think most vendors can do, either out of the box or with a little bit of custom work. I know in Utah, the APCD does have some geocoding involved, or the vendor does some geocoding. And as for linking in, social determinants of health data sets, I mean, it's a matter of a geospatial join. So I think most vendors have this capability or could quickly build it. But in Utah, we hadn't done any specific work in that area, at least as of my tenure there.
Let's see, the next question, Brantley, are you able to run time consuming tasks on raw data in async mode?
Yeah, and I'm definitely not a super big guru on the processing and how to run it. Usually I'll tell you in practice, usually I do. I'll have, multiple queries queued up. And whether that slows them down, in the long run, that I don't know, but that is something that you sort of have to do. You have to sort of work on one thing and then jump over someplace else. And I think ideally it'd be better if you let it run sort of, by itself. But in practical terms, usually you're working on a few different things at the same time.
Great, thanks. And just for those of you, if you can't see the chat, Norm commented that back to the geocoding question, there was an Igniter session about Colorado's experience. And then I'll just comment on that as well, just since we're talking about standardization. The tracking program, CDC's Environmental Public Health Tracking Program, has written geocoding standards for our recipients and partners, trying to kind of standardize the way that everybody is geocoding data and coding that to different levels of precision. So that's something, if you're interested in, you can email us, but we'll also be putting those up on our GitHub page for anybody to access those. We have another question in NCQA network adequacy reporting. A comment. Geocoding is necessary to determine provider and member distances. And then software exists to convert addresses to geocodes. All right, thanks for those comments. I guess we'll do one last call for any final questions for our speakers. Okay, and then just a reminder, Norm said that the slides will be added to from the presenters to the conference page for those presenters who authorized sharing the slides. So you can look for those after the conference. I just wanted to thank everybody again for their presentations. You shared a lot of insights on data standardization and tracking, not only for the pandemic, but also lessons learned that we can take into the future. So thanks again to everybody for presenting.
Thank you.